Okay.
Good morning and welcome everyone to the 7th Health Literacy in Action Conference. I'm Cynthia Baur from the UMD Horowitz Center for Health Literacy at the School of Public Health, and I'm here with my co-sponsor, Stan Hudson from the Institute for Healthcare Advancement. So we're very excited to be back with you for another year. We have a great set of presenters today. All hot topics. We know you will want to be with us all day long, but in case you have to step away, everything is recorded and will be available through IHA, and Stan might say a little bit more about that in the housekeeping details. So we hope you do stay with us throughout the day. And at the end, Stan and I will be back for a few closing remarks after our fourth presenter. So I'm going to hand it over to Stan just for a few opening remarks, and then he will take you into our first session. So welcome, Stan.
Hello, thank you, Cynthia. And welcome, everyone. We really appreciate you attending the Health Literacy in Action Conference today. Before we start with our first speaker, I wanted to just cover a few housekeeping items. Today during the sessions, all attendees will be muted, but you can use the chat for your comments and questions. And we will have a Q&A at the end of each session, so we'll have time and we'll be monitoring the chat so we can pull out those questions for the speakers. The sessions will be recorded and they will be posted within the replay section of Ring Central within about, it could take up to 48 hours. We will try to get them there and post it as fast as we can, but they do say it could take up to 48 hours. But they will be there for you and available for you to see for after the conference for quite a while. And then after about 3 or 4 months, we do make them available to everyone. So other attendees or people who didn't attend today would be able to see them eventually. Following the conference, you'll receive an email with a link to a brief online evaluation. If you're requesting continuing education credits for this, please, you do need to complete that to get that. But even if you're not, we ask that you please fill out that evaluation. We really, look through those responses, and it helps us as we plan for next year to make sure that we're providing good content and a good conference for you all that really meets your needs. If you need any assistance or have any questions during the event, our IHA team is here. And so feel free to reach out to us by emailing info@HLactionconf.com. So that's, let me say that again, info@HLactionconf.com. Or if you're having issues with Ring Central directly, there's a chat support in the top right corner that you can click on and get some help if there's something going on with your Ring Central interface. For the just kind of a little pro tip for the best experience, you do want to use the latest version of Chrome, and I would recommend closing other applications because that'll help a session. If it's struggling to load. If you do have a session that's not loading or is taking longer than expected, please refresh the page because it should come up pretty quickly. So I think that's all our housekeeping items for today. So it is my pleasure now to announce our first speaker, Dr. Claire Wardle. We're really excited to have Claire join us today. She is assistant professor at Cornell University, was previous at Brown, where she did a lot of work, especially around misinformation and handling those kind of issues, especially under COVID. That became a very big issue that everybody was realizing. And so we're really excited to have her speak today about the introduction of AI and how that's impacting the health information field. And so, Claire, I'll let you take it away. Thank you so much for being here.
Thank you so much, Stan, and good morning to everybody. Maybe good afternoon if you're elsewhere, but it's lovely to be with you today. And I love actually doing a talk where there's some good things. So in the title, I just tried to focus on the positives, but chatbots, translation and personalization, the opportunities and challenges of AI for health literacy. So as Stan said, I have a PhD in communication. I was in the School of Public Health, but now I'm working on a number of issues because unfortunately, as we head into an election, there is not one issue that is not impacted by our information ecosystem. But of course, lots of people want to talk about AI. And so that's where we're going to start. And I like to start my talks with something personal. And so I've just moved to Ithaca. So I've just got a new primary care provider and I just had my annual. And I'm not giving the game away. I'm of a certain age where these results are probably not surprising. But this is what I got back from my portal just last week as I was putting these slides together, which is somewhat being told I have an elevated cholesterol level. I have a 0.8% chance of a risk of a cardiovascular event. At the end, it says, please call me if you have any questions. Please reduce your intake of high fat / cholesterol foods, sincerely. And I had this moment as I was putting this slide deck together thinking, how is it in the year of 2024, where I'm giving these talks on AI and personalization, and we have more information than ever and more access to excellent information, that this was really what I got, with a kind of like, see you next year. And it really shocked me, even though I kind of, I theoretically talk about this, but when it's a very personal level, I was immediately searching, trying to understand, like, what should I be doing at what level? And of course, it's really hard. And it's not personalized information when you start searching, and it's overwhelming and all of the things. So I kind of wanted to root this talk in that moment of reminding us all of, we have these technologies, which means this shouldn't really be the norm in 2024, right? So we have to move in a way that does provide people with better information. But how do we do it in a way that we're not aware of the challenges that come with these new technologies? How do we make sure that we have the guardrails in place? How do we make sure that we're not missing ethical concerns, which means that in 10 years' time, we have a conversation, be like, why? Oh my God, the unintended consequences. So that's really what I want to focus on today in the talk, which is, what's AI in the context of health literacy? Some of you might be very familiar with these terms, some of you less. So I want to start and kind of make sure that we're all at the same foundation, try and think about the opportunities, and there's some really exciting opportunities. But of course, there's always a but. What are those challenges? And then kind of end, hopefully with a kind of a word of advice, but a bit of caution. So what do we mean when we say AI in this context, right? So of course, I search on Google Images for AI. This is what you get, some version of a stethoscope and a robot, right? That's kind of the default way of the ways that people think about AI, like robots. But that's not actually a helpful way, particularly when we're thinking about health literacy. And so artificial intelligence, of course, not new, has been around for a number of decades, a set of technologies that allow computers to perform tasks that normally require human intelligence. So for a long time, we've been using tools that were powered by AI. We just might not know. I mean, thinking about if we use Gmail, it might suggest the answers to our text. We know that artificial intelligence was being used and continues to be used in recruitment technology. You upload your CV and it tries to match you with people. We know things like mortgage decisions have had AI built into it. We also know the bias that has been found in some of these technologies, right? And that's not what this talk is about, but it's not that artificial intelligence is something new. We have been adapting to its use over the last few decades. But there are a new set of tools that is why everybody is talking about this, which is it's consumer facing and known as generative AI. So a type of AI that can create new content, such as text, images, music, audios, and videos. It's trained on large amounts of data and then uses those data, to learn how to create responses that are likely to be relevant to a given input, right? So that's what lots of people are talking about now, the idea that I can create an image and tweet it out that purports to be from Hurricane Helene, right? That's what people are concerned about when they talk about generative AI. I'm sure you've heard about ChatGPT. The free version was 3.5. It's going through iterations. It's getting smarter. But the idea that I can ask a prompt, I prompt this interface, and it can come up with all sorts of text, if I'm one of my students and when I write my essays, or it could be an image or other things. So OpenAI and others, we've got this new suite of tools, and I'm going to talk a bit more of those. And so LLMs is another term that you might have heard about, large language models. And that's a computational model capable of language generation or other natural language processing tasks. So when I was just talking about ChatGPT, that's an example of something that's really text-based, and it's looking for patterns in text and then creating other text from it, right? So LLMs is a kind of a subset of generative AI. And so you've also, of course, heard about chatbots. Chatbots are computer programs designed to simulate conversation with human users, especially over the internet. Chatbots often treat conversations like they're a game of tennis, talk, reply, talk, reply. And I think probably one of the biggest public health rollouts was between WhatsApp and the WHO at the beginning of COVID. And you could go onto WhatsApp and kind of choose your country and your language. And then you can probably see from the slide, you could, put in a number and it would tell you like, oh, I want my questions answered. So I'm going to press 3. I'm going to press 4 because I want to know the myths and I want to know the facts, right? So it's actually pretty pre-programmed. So it was kind of, you'd press a number, it would give you an answer, and it was back and forth. But it was pretty simplistic, even though it seemed kind of exciting. It was sort of like a website, but a little bit more interactive, but not that much. But that's distinct from virtual assistants, which is a software agent that can perform a range of tasks or services for a user based on user input, such as commands or questions, including verbal ones. The interaction may be via text, graphical interface, or voice. As some virtual assistants are able to interpret human speech and respond via synthesized voices, right? So this is an older explanation, but this is essentially Siri, Alexa, these types of particularly voice-activated assistants where you ask them a question and they give you an answer, right? So chatbots, pretty clear-cut, virtual assistants, a little bit smarter, but that's starting to change because traditionally there was this distinction that a chatbot is server or company-oriented, right? WHO decided what information they wanted to give back, whilst virtual assistants like Alexa or Siri are user-oriented. So it depends on what I'm asking them. I have more choices than that WHO version. But this is starting to change, right? So 3 main types of chatbots: rule-based chatbots, AI-powered chatbots, and AI agents, right? So this is where we're going. The next generation of bots equipped to autonomously handle interactions of all complexity. So if we go back to my starting example, an AI agent, I'd be able to say, hey, I think I just got some bad news. I think my cholesterol is higher than it should be. Like, I'm not feeling great about this. And then the agent will be like, oh, okay, Claire, let's talk about this. Well, and then it's this kind of very human feeling conversation, right? And that's really where we want to focus our attention today. We're not really at that point, but we're not far off it. And I certainly have students that have the voice activated version of OpenAI, which powers ChatGPT on their phones, and they talk to their devices like it's a friend. I have one of my students who talks to it for an hour as she walks home, and she has undoubtedly a power social relationship with her virtual assistant, but she's changed the voice to, in her words, a handsome man who she's fallen in love with. So that's the era that we're moving towards, but that's where we need to be really careful in thinking about guardrails. But I just wanted to give you a sense of when you hear versions of chatbots and virtual assistants, what does this mean? What does this mean for your organization? If you have a website, are we going to get to a point in 2 years' time where you don't have an interface of a website as we know now? Do you just have a search bar where you're prompting and you get a virtual assistant back? So we are going to see some pretty big shifts quite quickly in the ways that people can interact with information. So there's been a very rapid growth in the development of new generative AI platforms and the integration of AI capabilities into existing tools. So you might not have used any of the OpenAI tools. So ChatGPT, DALL-E, which is an image generator. They have a video generator called Sora that's about to be launched publicly. That's OpenAI is its own company, exceptionally well funded, and often in the headlines with their CEO, Sam Altman. It's getting a lot of traction, partly because of the money that's gone towards it. Another kind of competitor is Anthropic. They have their own kind of a tool called Claude, which is similar to ChatGPT. So those are kind of these kind of big, very well-funded companies. Hugging Face is a kind of a suite of tools and technologies that are what's known as open source. So OpenAI and Anthropic have their kind of their proprietary technology, and they don't want to share it. Hugging Face is about how can different technologies come together and build and share code. And it has a lovely name and a very cute logo. Then at the bottom, Microsoft, Meta, and Google, as you can imagine, the big players have been integrating these technologies into their own existing platforms. So if you use Microsoft technologies for Word or other things, you might have started seeing like Copilot suggests blah, 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 and it's going to help you with your writing or your images. Facebook, well, Meta, you probably have seen if you use WhatsApp or Instagram or Facebook, the search bar now will often say, you know, search AI. So it's integrated those things into their platforms. And Google, you've probably noticed when you search for something on Google, you now get these AI overviews at the top. And that's powered by what they call their Gemini tool. So we've got the integration of AI into existing tools, and then we've got these new tools. So many of you are probably interacting with these technologies, even if you're not necessarily aware that you are. And so I just wanted to make that clear as well. And so there's, as well as these, which are the kind of like user-focused, my mum might know about them tools, there's been the growth of other AI-powered tools that are helping transcription, translation, and patients understand jargon-filled advice. So in the field of health literacy, it's worth being aware of some of these things. And just to be clear, I am not advocating for any of these tools. This is just to say, wow, look at all of these that are available. I haven't done, this isn't like the New York Times Wirecutter where I'm telling you which is the best one, but it is kind of extraordinary, the startup scene, that people are developing tools specifically to help patients navigate exactly what I was showing you at the top of this talk. So when it comes to things like transcription, some of you might have used something called otter.ai, which if you're in a meeting, often in a Zoom meeting, you might see these automated notes being built, or on your phone, you can have an app. So sometimes I would use otter.ai if I'm having conversations with students, I would ask their permission, but at the end, it's automatically transcribing what I'm saying, right? And so we're seeing doctors using this. We're seeing patients go into doctor surgeries with their transcription tools on their phone because they want a full readout of the conversation. Sometimes it's because they maybe don't trust the doctor. Sometimes it's because they know in the doctor's office, they can't, you know, we've all been in that situation, either ourselves or our loved ones have had a diagnosis and our minds go to jelly, right? So these transcription tools help us come out and then reread what that conversation was. And whilst they're not perfect, they are pretty good at transcribing even focus groups, like different people speaking in one room. It's very good at picking that out. Another one is called Care to Translate. Talk to all your patients no matter the language. So a digital medical translator where the interpreter isn't available, right? So many of you potentially work in spaces where there are multiple languages being spoken and there might not be an interpreter available. And so we know language is one of the biggest digital divides. It doesn't get talked about enough. And so AI is a way to try and bridge that gap. And in fact, I haven't got a slide on this, but there is new technology. So imagine you love a particular podcast host, but you struggle to speak English. It's not your first language. There are now tools available where you could essentially hear your favorite podcast host. So you hear the voice, but it's in your language, right? So very, very quickly, the speed at which these AI systems have become really, really powerful and in real time for translation is something that's really going to kind of change the ways that people are able to interact, even if English isn't their first language in the US. Vital is another one. Finally, understand your medical notes. So we've all also been here, right? Often our notes get uploaded to patient portals before we hear from our primary care provider, and you're busy trying to figure out what's said, and you're Googling things, and you're calling a friend crying, being like, I don't know, I've just Googled this word and I think I'm going to die, right? So ways of trying to provide medical notes that are more user-friendly immediately is the goal of some other apps. We also have symptom checkers. So Symptomate, Buoy, Ada, there's a number of them on the market. And it's essentially doing what many people do with Google now, which is I've got a headache and I feel sick and I'm getting a nosebleed. What does this mean? And the idea is that it tells you what it thinks you have. And it also then often gives you some advice about what you should do next. And I'll get to some research later about they're not always as good at telling you what you should be doing next. But as you can see, these are all available for people to use. I have to just say, when you look at the small print of a number of these, you realize that all of the data you're putting into these symptom checkers are being sold, right? So why are these all free? Well, surprise, surprise, as we know about the internet, it's a way of collecting data and then personalizing ads to you and other things. In the medical realm, I find this deeply disturbing and problematic. None of this is yet being regulated, but I think people go, oh, this is exciting, and they're using these symptom checkers without checking the small print. And there are disease-specific patient navigators. So this is what AI-based patient navigator improves colonoscopy rates in underserved communities, right? So we can imagine the building of these for particular kind of things like colonoscopies, or somebody has had a particular diagnosis and has a kind of a personalized information navigator powered by AI, which is helping you navigate your treatments, navigating your appointments, and navigating your care routines, maybe even navigating insurance. I don't know, I can't imagine that, but you can imagine these very personalized navigators designed for particular illnesses or diseases. And then health literacy tools. So this is one I tried to sign up, but they said, you're not a patient advocacy group. This one is powered by Pfizer. So I don't know, and I haven't had a chance to look at it, and maybe some of you in the audience have. But they have basically developed this health literacy tool as part of their patient advocacy leadership collective. So as you can see, there is a number of these tools that are being built. I would argue that the evaluation of these tools has not at the same level. There are not enough academics working, I would say, with practices to evaluate the success of these. But as you can see, there's definitely this potential market for building them. And I think it's great to see that there is a recognition that health literacy is an outcome that technologists are thinking about. I think there's a question here around who's going to pay for it. Is this about collecting people's data? Is it about advertising? Is it about subscriptions? That's for another conversation. But you can see there's a number of these tools out and about. So, of course, there's real opportunities here. So simplifying what's confusing. I am not somebody who is able to read the New England Journal of Medicine. But what I like to do sometimes is to take an article that I cannot read because I am not this kind of scientist, and I will put it into ChatGPT and I'll say, can you simplify this? And it will go through this very hardcore medical article and it will simplify it. And if you're still not sure, you can say, for this is one, I said, could you give me the simplified version? So it did that. And I said, actually, could you simplify it for a 10-year-old to understand? And it came back with this, right? So the thing about these tools is that you really can ask it to simplify things that you don't understand. And because it is trained on so much data, lots of the data actually are social media posts. So interestingly, it kind of, yes, is trained on scientific content and kind of academic writing, but it also is trained on lots and lots of writing materials that are actually, I would argue, more effective at communicating. So it's pretty good at simplifying quite complicated ideas and communicating quite effectively. As we've just mentioned, very good for reaching people who speak other languages. I use this map a lot to remind people after English or Spanish how many different languages are spoken in this country, and really trying to understand how and where people are getting their information. We had a fellow last year who worked with her Vietnamese community in Oakland, many of whom spent hours all day long on YouTube because it was the only content they could get in Vietnamese. And I think all the time about the absence of good quality information in local languages and what that means, particularly in the healthcare setting. So I think, to me, the translation capabilities of AI are really exciting. And then, of course, optimizing personalized care and hopefully empathy. So you have probably seen some of these studies. I don't like citing them because I think we haven't got a big enough body of evidence yet, but we've definitely had some studies that are starting to show that actually kind of these chatbots, ChatGPT powered technologies are considered more empathetic than people's interactions with actual humans. And they use different methodologies. And as I said, I think it's a little bit problematic to say these technologies are more empathetic than all doctors. But I think we all know, and there is certainly literature to suggest that not all primary care providers or people working in healthcare settings are as empathetic, even from the basic not asking people their names. Like we know in this field that it is an issue. I think what's interesting here is recognizing that the way that these tools are being trained means that empathy, this kind of two-way conversation, which is deliberately being designed as a way to make people more trusting of the output. I need to say that now. Like these technologists have said, we've got to build something that people are going to trust. What's one way we can do that? Well, let's make it sound more human. Right. So by doing that and by building that into the design of these technologies, we actually have got tools that are polite, that ask questions, like do things that are like pretty human in a good way. And in fact, some colleagues, one of them is here, Gordon Pennycook, and his collaborator, David Rand, have just done a study with ChatGPT and found that it's very effective at talking to conspiracy theorists and is actually more effective than humans at making the conspiracy theorist less likely to believe the conspiracy, because the bot is able to listen to what the person is saying and really reflect back what they're saying based on the evidence they have. So rather than like, no, Uncle Bob, you're wrong, and this is why you're wrong, I'm right, you're wrong. Like we know that, we've all had those conversations at Thanksgiving dinner tables. In the interaction with ChatGPT, it was like, oh, Bob, that's so interesting that you feel that. So empathy was built in and was actually more effective. So again, I want to be careful and not make these grand claims that, we don't need humans anymore. I do hope that some of these conversations are making people working in the healthcare industry think a little bit about how we've got to prioritize empathy. But I'll also say this is because of resourcing, not enough staff, et cetera, right? So I just want to put all those caveats in. But I do think there is a real opportunity for people, again, going back to the top, being told they've got elevated cholesterol and thinking, how do I tell this person this? Think about what they might be concerned about and give them actionable items to do, so makes them feel some agency, right? So thinking about that way of adding personalization and empathy into our communications, I think is a really interesting part of what AI can do for us. Challenges, they are real. And of course, as Stan said, most of my career I've spent studying misinformation. I spend a lot of my days in what I call the armpit of the internet. And unfortunately, we know with AI, this is a problem. And there have been many headlines about what's called hallucinations. And I have certainly seen that with some of my students. They'll hand me something that sounds great. And I'm like, oh, that's an interesting citation. I haven't heard of whatever, Smith and Kelly, 1999, and you go looking for Smith and Kelly 1999 and it doesn't exist, right? So unfortunately, the AI has been built in a way that it's finding patterns and it's building up knowledge based on those patterns. And so part of the thing it can do is like, oh, I'm sure there's a citation. This sounds like the kind of citation that would exist, right? So the technology is saying that we are seeing a decline in hallucinations. We don't have good benchmarks on this. We don't have consistent enough auditing to know whether hallucinations have come down, but it's the number one concern people have around misinformation. But I just want to give you an example around sunscreen. So you have probably heard some people say, oh, I don't use sunscreen anymore. I've heard that it's dangerous, right? And the first time I heard this, I was like, oh, this is really niche. And then this summer, I was kind of amazed how many people I know who I would not have expected this, telling me that they were no longer using sunscreen. I was like, this is crazy. But I wanted to show you this example. So in Google, I searched with the prompt, should I use sunscreen, right? So this is the positive framing. Should I use sunscreen? And at the top, you might be able to see the AI overview. Yes, you should use sunscreen every day to protect your skin from the sun's harmful ultraviolet rays. Great, thanks, Google. That's what I need you to do. But what's interesting is if I reframe the question by using the kind of rumor or the myth in the headline, does sunscreen cause cancer? So I flipped it. And this could be the thing that I've heard on Instagram or TikTok, and I'm coming here to check. Google right now is not very good at using AI to respond to myths. And I saw the head of Google Health talking about this, and she said, on anything that is dubious and we're not completely sure about, which I was like, well, that doesn't make sense because you are actually doing a good job on the other flip side. But you can see how the prompt can change the results. The results are still good, like 9 sunscreen myths debunked is the second one, but there's no AI overview. So again, you can see how these technologies are having to evolve based on what the prompts say and making sure that they're not making any additional errors. But one of my worst technologies right now is Alexa. So I'm doing some research right now with participants to try and find out how they're searching for health information on Google, Alexa, and ChatGPT. It's fascinating research. But one of my participants asked Alexa, "Is sunscreen bad for me?" And this is a response from BeWellBuzz.com, that well-known website. Sunscreen ingredients are well known to cause poisoning, hormone disruption, degenerative changes in cells to the skin, DNA damage, free radical generation leading to premature aging, a compromised immune system, and increased risk of melanoma. So that, my friends, is on Alexa, just out there from BeWellBuzz.com. And this is, essentially powered by AI in the sense that Amazon, I don't actually know how Amazon's Alexa makes decisions about which sources to pull from, but this is clearly not a good one. So there's questions here. It could be that BeWellBuzz.com has a lot of affiliate links, who knows? But all to say, we have to be very careful and make sure that we are auditing on a regular basis any of these technologies for questions, both the kind of flip questions, the myth, the truth, and to see what kind of answers we're getting. And we have to be very clear about that. As a side note, Alexa is also spilling misinformation right now about Hurricane Helene and saying that it was deliberately created by the government. So if you ask me, we should be shutting down Alexa for anything other than, do I need an umbrella today? As you can see, that misinformation is a real challenge and something we need to be concerned about. The other area is an area that not necessarily a problem just for AI, it's a problem more generally for effective communication and health literacy. And that's kind of issues related to unsettled science. So something like Lyme disease, on something where we're still trying to figure out best treatments, we're trying to figure out people's lived experience. There are people who are turning to communities to try and find answers. So if I just go to Facebook and search for Lyme disease, you can see all sorts of Lyme disease support groups from right around the world, right? So people who are struggling to, as they perceive it, to get good information from a scientific community, a medical community that are trying to figure this out. They're going to places like TikTok and Facebook, and they're finding all sorts of information. Now, in these spaces, whether it's Lyme disease or long COVID or other types of areas where we are still trying to figure out best practices and guidelines, unfortunately, AI is really bad here, right? Because it doesn't have a corpus that it can draw from with conclusions, right? So it's bad for AI. It's also not great for us more generally. And as we've seen with the pandemic, whenever we have something new and we're waiting for results and kind of consensus, that's when communication breaks down because the certainty isn't there and it's very difficult to communicate uncertainty. And so when we have those kind of vacuums, that's unfortunately when we see misinformation filling those vacuums. And so that also is an issue for AI. And so this is something that I put into chat. Should I be worried about multiple COVID-19 infections? There's many different beliefs about where we are with multiple infections, right? AI is just struggling to know how to do this. So it comes up with different answers, but this would be the same if I asked Google. It would be the same if I asked my friends who are doctors, right? Like this. So we have to also do a better job of educating users of what does it mean to use these tools on an issue where there is not one consensus, right? So that's actually a bigger literacy question, but I wanted to bring that up in the age of AI where people kind of are looking for this definitive one answer, because we know from years of us learning how to use Google, oh, look, there's 33 million results. I'm probably only going to look at the top 3, but I'm going to compare and contrast those top 3. In an age of AI and these chatbots, what we see is people kind of like, they like this. And from my research, I see people go, oh, this is easy. I don't have to click on different links. It's just telling me the answer, right? So we need to be really aware of that shift. Of how we've gone from this idea that there are multiple sources and you do your own research to, oh, this technology is going to give you the answer. And even if it tries to build in nuance, that's a pretty big shift. And as you can see from these answers from ChatGPT, there's no blue links to click on, right? It doesn't even list its sources. It's just almost saying, trust me, look how professional I am. I've got some nice numbered bullet points. I've got headers that are bolded, you know, like this just looks professional. So in all of that, in my research, I find people loving it. And then they're like, oh, where are the sources? Well, not to worry, it's giving me some really good answers, right? So we can see this evolution is happening really, really quickly. And so translation, one thing to say is, yes, there are real opportunities with translation, but we also have to be aware that studies have revealed that these LLMs, these large language models, are trained to think in English, right? So often, say you're asking a question in Hindi, it's translating it back into English, doing the search in English, getting the answer back in English, and then translating it into Hindi, right? So what this means for cultural differences, when we did our research, we did it with some first generation Chinese Americans who were just like, well, this doesn't give me anything that I would get in China. Like, I'm looking for non-Western answers to my questions, right? So what does this mean for cultural differences? What does this mean for indigenous practices? There's a whole host of things to be very careful about. So yes, it seems amazing that we're able to do this translation, but we also have to be very aware of this training, for the most part, is happening using English models. And then in terms of quality of advice, this was one of my colleagues at Brown in the School of Public Health. He was the one who went and did some research on symptom checkers and basically audited a number of symptom checkers around kind of different symptoms that people would put in. And what he found was that it was pretty good at checking somebody's symptoms. Say, you know, I'm a woman, am I having a heart attack? It was pretty good at figuring out some of that stuff. What it was less good at was what it would say. So some symptom checkers would be like, immediately get into an ambulance and go to ER, and other people like, oh, I think you can sit down and have a cup of tea and a biscuit. I mean, not quite that different, but his point was there's kind of accuracy of diagnosis, which is different to the triage question here of like, who should we be sending to ER or not? So I think, again, thinking about auditing and what questions we're asking is really important. And finally, this is from a good friend of mine, Craig Spencer, who's also at Brown, who wrote in last year in Stat and just said, oh, AI can't replicate this key part of practicing medicine, which is why I'm really careful about trying not to say, oh, AI has got more empathy. You know, to Craig's point, you know, he's like, he's an ER doctor, and he's like, every single day, I'm sure the decisions I'm making are the same as AI, but there's one patient every single day that does not have the expertise that I have. But there's also one patient a day that maybe AI would spot something that I wouldn't, right? So we just have to be really aware of how can we use AI to boost humans and their skills and their lived experiences and their knowledge, and not necessarily see it as one or the other. And very finally, and I haven't gone into details here, but I've mentioned it a couple of times, things like data collection, privacy, ethical concerns. You know, the thing about collecting data for individuals around their health decisions is very different from generally collecting data on my habits of buying black tops so they can target me with more black tops that I want to buy. Like, that is fundamentally different than me, you know, the kind of sucking up of all the data about my living habits, whether I smoke, whether I drink, how many steps I do a day, all of those questions being used to provide personalized answers, but also potentially being used 20 years down the line to not give me insurance, right? So all of these issues are packaged up in AI only works on the basis of very good data collection. And what does that mean when we're talking about healthcare? And what does that mean in the future if we don't have good guardrails? So just to end, just to say, I would say be open to what's possible. You know, I get up every day still really hopeful about how this technology can make the world we live in better. And I try where possible to stay across some of these advances, although the speed at which it's happening is incredible. There's a couple of podcasts I tend to try and listen to when walking the dog. And every week, even the hosts are like, oh my God, you can't believe what's happened this week. But I'd also say we've got to tread carefully. Please beware of those snake oil salesmen. There is a lot, as you can see. I gave you all those screen grabs of all these AI startups. Those websites are beautiful and promise so much. But we have to evaluate and really figure out whether this is working for us as practitioners, as researchers, and also, most importantly, for users themselves, for people, not users, people. And until we evaluate it, we should not be buying and rolling out these tools without really understanding what those unintended consequences might be. So I think we have a few minutes for questions if anybody has them. But this was meant to be just kind of an overview to try and get your juices flowing as you move through the rest of the conference. But yes, if anybody has any questions, I'd love to answer them.
Hi, Claire. I've noticed a few in the chat, so I guess we'll take care of the big elephant in the room. What are the potential issues with HIPAA?
Ooh. Okay, so so I'm not a lawyer, but I do find it kind of astonishing that during COVID, we were having to, fax everything, because when HIPAA was written, there was a sense that fax was the one thing that was secure enough, and so all of these faxes were flying off machines. So I think we know around deep fakes, for example, the law is way behind. So I think it's a really good point, and I should have included HIPAA, but partly I don't know the answer, right? And I think we will have a case that kind of pushes this and makes people think about it, because it's going to have to. But I mean, HIPAA was great when it was written, but I think 1991, the fact that it's still, I've moved to Ithaca, trying to get my medical notes from Rhode Island has nearly killed me, right? In an age of AI, it's basically putting a CD-ROM in the post, right? So we have to update this. So that's not a good answer, but I suspect that there will be a case that will force HIPAA to change and be updated. But my hope has the guardrails that we don't do something that we then live to regret.
Thanks, Claire. Yeah, I just had to have surgery at a different system, and a lot of fax machine was involved. I was amazed at the fax using. But here's a great question. I'm really looking forward to this one. Someone asked, but what about cultural safety? AI is currently whitewashed and not informed in Indigenous knowing, being, and learning.
Yeah, no, I mean, exactly to my point, when it, for example, talking about non-Western medicines, talking about different cultures who have very different lived experiences of the public care sector themselves, people who are less likely to trust doctors. I mean, what I would love to see, and when I put up that model of Hugging Face is this idea, like, it's open source. What does it mean to bring the lived experiences of different communities to the design table to say, okay, let's stress test these technologies and have people like, this doesn't do anything for my community, and it doesn't bring in any of our lived experience. It doesn't talk to me. I don't trust it. And I think we need some of those high level conversations, because at the moment, I mean, you may remember when there was the rollout of Gemini, Google basically had to apologize. They had images of people wearing Nazi costumes that were people of color. And people were like, what's this? And it was like, because they were trying to over-index because they were aware that it was whitewashed, but they did it in a really clumsy, horrific way. And so at the moment, there is more concern about representation issues in images. But I think this point, particularly in public health and media literacy, has to be about different cultural understandings of care and lived experience and healing. And absolutely, the idea of bringing Indigenous voices to the table is critical. So I love that question. And I think going back to the speed point, we know these technologies are being funded by these VCs in Silicon Valley who are desperate for a very quick profit, right? So that's why we're seeing this insane hockey stick. What we need to see is, hang on, like, this is not just about profit. What does AI look like in the public interest? What does AI look like that really serves the needs of different communities? This is not about shareholder value. This is about public interest. So I'm not surprised it's not happening right now. I'm disappointed, but I'm not surprised. My hope is that we can have more conversations about what does this technology mean when designed by and for people who do not look like me.
And it kind of goes to the next question. I just realized I can show these questions, so I'm going to do that. What about gender bias and how that is currently built into AI?
Yeah, I mean, unfortunately, the biases are built in based on, what the training data says. So this is not the case anymore, but for a long time, this was my favorite teaching example, which I would go to Google Images and put in like image of CEO. And of course, all of the images were men. The only one that wasn't was CEO Barbie, right? And I'd say that's not because there are misogynistic men in Silicon Valley. Might be a few, but this is because we don't have enough training data of women CEOs, right? And that luckily has changed, and Google figured that out and have changed. But really there's bias to do with race, ethnicity, a whole host of different representation issues, because we don't, because that exists in real life. So the challenge here for technologists is to say, how do we ensure that we're not relying on existing biases and discrimination that exist within our societies? So at the moment, there's a lot of concern about race, quite rightly, slightly less on gender, but it does come up when we have like a long history of, for example, women not being taken seriously. So the obvious one in health literacy is, as a woman, what are the symptoms of having a heart attack? Well, they're very different to men. Luckily, there's actually quite a lot of data out there. And so the AI systems are pretty good at figuring out that difference. But you can imagine other situations where we have yet to figure out that there's a gender bias because all the studies have always been done on men. They're the kind of things that we will see replicated by AI. So that's the kind of stuff that we have to be really attuned to.
Okay. The next one. How can public health evaluators advocate for changes to AI responses to subject-specific questions in their systems?
It's a really good question. I mean, I think, as I've sort of alluded to, we just need to really build out really good auditing systems, right? We need to have benchmarks, and we need to, so the subject-specific questions, just playing around with it, I mean, I'm actually increasingly doing this with my students to say, okay, can all of you do this? Yes, last week we were saying, if you prompt in ChatGPT and you say, I live in Texas, I tend to vote Republican, I support the Dallas Cowboys, like you're kind of doing a persona that's more likely to be right-leaning, and you ask them what happened on January 6th, and then you do the same, but you say, I happen to be from Rhode Island, and I'm pro-abortion, blah, blah, what happened on January 6th? You get very different answers. You get very different answers if you ask about trans rights. You get very different answers if you ask about a whole host of things, right? So it's not just what answers do you get, because there's many, many different prompts you can do. And if you prompt as a persona, you also get different answers. So I'm not answering your question very well, other than to say we should be having more conversations about what kind of audit should we be doing, and how can we, over a regular period of time, make sure that we're adding that into the work that we're doing. Maybe that means with partnering with more universities to do those kind of audits, but it's a really good questions about changes to AI responses. Then it's a case of writing op-eds, unfortunately. Like it's a case of having to like bang the drum, talk to legislators to be like, hey, did you know there's a real issue going on with Alexa, or there's a real issue unfortunately, there isn't an easy way to get those responses improved other than to talk more loudly about it. And just very quickly, I'll say this. For all the multi-stakeholder AI meetings that you've probably heard about at the highest levels, communities are never around the table. Just completely absent, right? The people from a whole host of different backgrounds are not around the table when AI regulation is being discussed, or safeguards are being discussed, or guardrails, right? So to me, it's also at the local level, there's more happening at the state house level than federally, like how to bring community groups to those conversations to talk about the ways in which their communities are being affected by AI. So.
You talked a little bit about HIPAA, but there was another question around what are the legal repercussions that we need to think about when using AI to formulate health literacy patient information?
Ooh, Michelle, that's such a good question. Do you have a lawyer in your audience? I don't actually. I don't actually know. I mean, the FDA put some good things out recently for companies around responding to misinformation. So I don't actually know where the FDA is on this. It's not quite what you're talking about. But I think that the legal repercussions of so many elements, whether it's responding to misinformation, whether it's formulating health literacy patient information, I just feel like the law is way behind. And I think, to be totally honest, I think some of the federal agencies are also way behind. So I don't have a good answer here. And I think it's a case of thinking about what you would do without AI, and then, really like, I think somebody's put in the chat, like lots of us use AI just to kind of improve things and streamline things and think about organization and all those kind of things. So I think you probably wouldn't put out anything that had been generated by AI that you hadn't checked anyway. But it's a great question. I don't really know the answer. And Stan, maybe try and find a lawyer before the next session.
All righty, let's see. We've got time probably for one more question. Let me look in here. Oh, it looks like we do have a lawyer in the audience. Here, I'll just show it so you can see. Government is so far behind. So there's some. Let's see. Here's one. Would using closed data training sets solve some of the problems you've identified with misinformation?
Oh, that's such a great question. And certainly on things that we absolutely have consensus around, yes, that would really, really work. I think and I think for sunscreen, I mean, yeah, there's some nuance around the edges, and of course there are some concerns about minerals, and there are some people who want you to spend more money on very expensive sunscreens that don't have those minerals. But I think fundamentally, this idea that Alexa can tell you that sunscreen causes cancer, there is no excuse for that happening. I think the challenge, and we know this with the term misinformation, right? That increasingly misinformation gets used on something that we're not 100% sure about. And I think during the pandemic, unfortunately, things got labeled as misinformation, which then those labels had to get taken off when science kind of, changed. So, at the beginning, we thought that COVID would prevent us from getting the virus. Now we know it doesn't prevent us. It just makes us less likely to get sick, right? So I think the challenge on anything that's kind of unsettled, that becomes slightly problematic. So, but I do think for things that there really is consensus around, there should be a smarter use of using closed training sets. But right now, the term misinformation has been weaponized, and there would be a number of people that would be very concerned about, well, who's choosing what those training data sets are, and who's making the decision whether or not this is true or not. Around ivermectin, you can imagine that, right? You can imagine many of us would not want that to be anywhere near the training data set, and other people saying, yes, it should be. So that's the problem with misinformation. There's a lot of conflicting voices on things. I wish we had more consensus and we could have agreement. Without that agreement, it would make this quite tricky. But yes, in theory, what you're saying is absolutely right. In practice, a little bit more tricky.
All right. Well, one last thing, because this will be a quick question. We're asked, what podcast do you listen to?
Oh, there's quite a few, but the one that I really enjoy actually is called Hard Fork. And it's a New York Times one, and it happens at the weekend. And there's two, Casey Newton and I can't remember the other co-host, but they're very good at kind of keeping me on track. And if you listen to it at double speed, you can like figure out the bits that are really wonky and bits. But I think they have a really good way of making quite complicated things really accessible.
All right. Well, thank you so much, Claire. We really appreciate you being here today and sharing this information. I think we're all starting to deal with AI and how best we can use it as a tool in health literacy. And so we really appreciate all your thoughts and answers today.
Thanks, Stan. Thanks, everyone, for your great questions. Really appreciated it.
Thank you, everyone. We have about 8 minutes before the next session starts. So please go take a quick break, and hopefully we'll see you at the next session. Thank you.